Hi, this is Elliot Fishman, and welcome to part 2 of our discussion of the greater than 4 centimeter adrenal mass. And we left off with this slide last time, and I like this slide because it shows you how many different benign lesions can be large. We typically think of adenomas as 1 centimeter, 2 centimeters, and indeed that's true if you look at your daily practice, but they can be large. Cysts can vary in size. Myelolipomas will discuss how above a certain size the chance of bleeding is higher. We'll talk about things like hemangiomas or lymphangiomas or even ganglionomas, benign lesions, particularly hemangioma and lymphangiomas, but again, can you make the diagnosis? And of course, hematoma, prior bleed or acute bleed. Obviously, a patient who's had trauma, who's on anticoagulant therapy, the diagnosis is usually very straightforward. But other times, the hematoma, the bleed was previous, and now you simply see a large mass that has a thick wall and maybe some increased density. And is this a hematoma or is it a malignancy? So it's not going to be always as simple, but let's go through these. This article by Chung, a good article in Radiographics, talking about the importance of multidisciplinary conference for adrenal masses. It may be impossible to distinguish a large atypical adenoma from an ACC or other malignant mass with imaging features because of overlapping imaging features. If there are no benign diagnostic features, evaluation of the clinical context, including hormonal assessments, is essential for assessing the need for surgical resection of a 4 cm or larger mass. Patients with a large mass should be managed by a multidisciplinary team. Could not agree more. And this is the problem, because a lot of these benign lesions, you saw the list from the Mayo Clinic, only a third of the tumors above 4 were actually malignant, so 2/3 are not. 2/3 probably could have been left alone, but you can't always do that. The article goes on to say that adenoma is the most common benign adrenal tumor arising from the cortex, whereas ACCs is a rare malignant tumor. Cysts and myelolipomas, pheochromocytomas, though 10% are going to be malignant, 10% are part of syndromes, but also pheos 90% of the time are hypervascular. You're not going to confuse a pheo that enhances above 120 typically with an adenoma or a cyst. So in that part, when lesions have very, very classic imaging appearances, it makes life a bit easier. But I'll show you, even with pheos don't always follow the book, because you have a certain percentage that are cystic pheos, and then they could really look aggressive. It looks like a necrotic tumor, though typically they maintain often that cystic shape. But again, it can be somewhat difficult, and we'll talk about that. More recent data has shown that the numbers of Hounsfield units are not as specific for adenomas as we believed, and washout can occur with other lesions. And I mentioned pheochromocytomas, but I think a critical point is typically we'll use a number like 120 HU. If a lesion is above 120 Hounsfield units, I don't care how much it washes out. To me, it's a pheo till proven otherwise. And of course, history, hypervascular Mets. You have renal cell carcinoma and you have hypervascular adrenal lesion, you're not going to worry about it. It's going to be metastasis. And often you'll need old scans, because typically adrenal Mets occur in patients who've had prior adrenalectomies. And so you have comparison films. So it can be somewhat simple, but I think the part about looking at history, looking at old films, all become very, very critical. Now, it's interesting, people are kind of becoming a little bit more careful when you're looking at growth over time. So if you look at adenomas, and sometimes I see cases where it's a 3 centimeter and it was 2 centimeters 6 years ago, then everyone worries that it's growing. But adenomas do grow, but less than 3 millimeters per year, while malignant tumors grow greater than 5 millimeters. So that may be a very helpful thing. If you have an incidental lesion and nothing else about the lesion, and it's not perfect for any one diagnosis, and you have an old scan and it's the same, or it increased by just under 3 millimeters a year, you got to be focusing on benign etiologies. Over 5 millimeters a year, you got to really think about malignancy. So again, it can be very, very helpful. So stability is one of the best findings. Stability is true for adenomas often. It's true for hematomas. Hematomas can get smaller over time, particularly in the first 6 to 12 months, but then they reach sort of a point where they stay the same. Staying the same is good. Metastasis or primary tumors that are malignant are going to grow in terms of size. So let's look at a couple cases. Here's a 5 centimeter left adrenal mass. It measures about 20 Hounsfield units, so you can't call it an adenoma. Well defined, somewhat round. And when you give contrast, it enhances to 80. Not the most vascular lesion, so I'm not thinking about a pheo, though I've seen some pheos that are not hypervascular. But you would have had lab values, and the lab values would be good, or you'll get lab values. Very well defined, so it doesn't have any aggressive features, and is kind of coming off the bottom limb of the adrenal gland. Here it is with 3-dimensional view, looking at it. And what was that? It was an adenoma. Or this case, look how large this right adrenal lesion is. You can argue that's the kidney, but it's the adrenal, and it's 10 centimeters. So you're thinking malignancy, but then you see prominent vascularity at its edge. You can see it almost looks like, and I thought about this, could this be a hemangioma? Because if this was a liver lesion, peripheral puddling always makes you think about hemangioma. It's pretty well defined and it's smooth. When you do MIP imaging, you can see some of the prominent vessels. It doesn't have the neovascularity I would suspect to see in an ACC. And ACCs are not typically so perfectly smooth. And as you go from the early phase to the venous phase, you can see the puddling increases very much like hemangioma. And again, I'm thinking it's an unusual tumor that's vascular. Hemangioma, lymphangiomas aren't so vascular. Neurogenic tumors, they're usually lower density, and it's just some of the puddling around the edge. You don't typically see that with malignancies. This was resected because looking at it, it's hard to figure, and it's 10.5 centimeters. Anything that large is coming out. The patient also had some symptoms, which probably just related to the size of the lesion and how it sits against the crus of the right hemidiaphragm, and this was an adenoma, a benign lesion, making the point that adenomas can be big and adenomas can have unusual enhancement. When you think about all the adenomas you've seen, we talk about washout values, but I can't remember more than 1 or 2 others that ever had prominent vascularity like that. And here's another case, very much like the first adenoma I showed you. It's 5 centimeters, very smooth. It enhances to about 80. It did not have the washout of a typical adenoma. But then when you look at the coronal in the lowest part of the lesion, there's this low density, which is fat density. So I thought actually this was a lipid-poor myelolipoma, because whenever I see fat in a lesion, it's either a myelolipoma or carcinoma. But carcinoma, you see lots of irregularity, lots of neovascularity, and typically invasion of the perirenal fat. So to me, macroscopic fat means a myelolipoma. Well, the truth is, though we rarely see it, adenomas can have macroscopic fat. This lesion was resected and was an adrenal adenoma. So very, very interesting. Article by Chung again makes the point lipomatous and myelolipomatous degeneration occurs in primary tumors such as adenoma and rarely ACC. It is much less common than in myelolipomas, okay? But again, every once in a while, macroscopic fat can be in an adenoma. Again, I'm making the point that when you have a malignancy like an ACC, there are many more features. You're not really paying attention to the fat. Now, the good news is whether something ends up being a myelolipoma or an adenoma, if it's under 5 cm, the management is the same. With myelolipomas, then you're going to do a adrenalectomy because you're worried about the possibility of subsequent bleed. It's interesting, of course, myelolipomas with minimal fat tend not to bleed. The more fat in a lesion, the more likely it is to bleed. Remember, we used to do studies looking at the vascularity. When you see lots of AV shunting, those are the lesions that are more likely to bleed. So that becomes very, very important. Now, when you talk about adrenal lesions that are benign, adenomas, we talk about that. Then we talk about adrenal cysts. There are 4 types of cysts: endothelial, pseudocyst, epithelial, and parasitic. Now, you can have hydata disease involving the adrenal. I once saw a case. But typically, endothelial cysts or pseudocysts make up more than 80% of cases. Endothelial and epithelial cysts are usually thin-walled. They can contain calcifications. Pseudocysts have thicker walls. But again, we usually can tell it's benign. Here's a typical adrenal cyst. Its water density here is measured 15, sharply marginated. There's a little something, which is an adenoma, in the contralateral left adrenal gland. Here it is in coronal views. Well-defined water density, nice interface to liver and to kidney. Here's another example, left side. Water density sharply marginated, no enhancement of note. Here it measures, even with contrast, just 15 Hounsfield units. So you can see not much of a differential diagnosis. As long as you're convinced it's from the adrenal gland, it's very easy. Usually we have no problem with, remember I showed you that foregut duplication cyst before. But again, that case looked different. The shape was different. It wasn't perfectly round, and the patient did have some symptoms. But adrenal cysts, very nice example here. And cysts can be large. One of the things also, there's a recent article from Hopkins that makes the point that when you have follow-up on cysts, you can see that they can grow over time. It's been shown that a lesion under 10 centimeters you can watch. There's no increased risk of rupture. There's no increased risk of bleeding. But once a lesion hits 10 centimeters, you'll want to resect it. You can do it laparoscopically because it's a benign lesion. Here's that adrenal cyst, very nicely shown with cinematic rendering. And you can see this one measured literally 19 centimeters plus in size. Sometimes when it's this large, you're kind of thinking, could this be a liver cyst or a renal cyst? But this was an adrenal cyst, nicely shown again on the patient's cinematic rendering from both a volume rendered cinematic view anteriorly and laterally. In this article by Rodriguez, and this is the article from Hopkins, adrenal cysts are rare and management often unclear. While size over 4 to 6 cm has guided surgical referral, the study demonstrates that 10 centimeters below which asymptomatic simple cysts can be observed. So this article was very good because they're saying if you have a 9 centimeter lesion, maybe you want to follow it that doesn't keep on growing, but the answer is there's no need to resect it. And classic literature, above 5 or 6 cm, everyone recommended surgery. We looked at a large series of cases, and this indeed was not the case. In studies that merged management of cystic adrenal lesions with simple cysts, authors recommend adrenalectomy greater than 5 cm. But when it's simply separating out the cysts and the cysts only, then under 10 cm, you don't need to worry. So that's a very good talking point. Large cysts, those above 10 cm, tend to grow more rapidly than smaller cysts. And that's why at 10 cm, you're simply going to resect them, even if the patient is asymptomatic. Now, another benign lesion, which can be challenging, is lymphangiomas. The truth is they kind of look like, in many ways, like a simple cyst. Lymphangiomas have smooth, thin walls, but they may have calcification. But truthfully, occasionally, cysts have calcification. Adrenal cystic lymphangioma is a type of adrenal endothelial cyst. It's congenital development from primitive lymphatic vessels. Again, it's very, very uncommon. Like most cysts, adrenal cystic lymphangiomas are commonly asymptomatic and incidentally detected. However, it compresses adjacent structures. Patients can have symptoms. But of course, this is true with anything in the adrenal. The most benign simple cyst, if it gets large enough, pushes on the crus of the diaphragm, pushes on the stomach, can cause symptoms. In terms of CT, sharply marginated, low density, again, smooth walls, occasionally have calcification. I think at times, probably most times, it's really hard to be specific that it's a lymphangioma because you'll see the couple cases I show you, I surely probably statistically would think about a cyst. Here's a large cystic lesion. Patient had mild symptoms. very well defined. It could have been in the prior section on adrenal cysts. Doesn't enhance with contrast, water density. There's the most faint calcification near its edge, but I told you that cysts can have calcification. This measures with contrast less than 20 Hounsfield units. Be perfect for a cyst, but it was a lymphangioma. Another case here, cystic lesion, 13 Hounsfield units with contrast, a little faint calcification inferiorly. Again, I think what you could say here is this lesion is benign. I favor a cyst, but I guess maybe you need to think about a lymphangioma if you were giving a differential diagnosis. If the patient is asymptomatic, you simply follow the patient. If the patient is symptomatic or the patient has other issues, perhaps you'll go and remove it. This was removed. The patient was very concerned about the lesion, has faint calcifications. I was thinking cyst, but the multiple faint calcifications, you got to think about lymphangioma as well. And this was resected and was a lymphangioma. Now, myelolipomas are a third lesion. I really like myelolipomas. Usually you can be very, very specific in making the diagnosis. They're always benign. They're always non-functioning, usually in older patients. They have calcification commonly in addition to fat, and that can become very important, particularly in the lipid-poor myelolipomas, and size can vary from 2 cm to 17 centimeters. They typically have macroscopic fat, which is rarely seen in adenomas, though I did show you a case, and really rarely seen in ACCs, but again, as I mentioned, the ACCs are aggressive-looking tumors. The problem with myelolipomas, they can spontaneously bleed, and so if the patient has discomfort or pain, an atypical appearance, you're not sure it's a myelolipoma perhaps, or it's over 5 centimeters, most endocrine surgeons or urologic surgeons will remove them just because of the chance of bleeding. So here's a good example. This was an incidental finding, a vascular 8 centimeter left adrenal mass. One thing I'll mention, when you look at these images here, if I told you this was a liposarcoma, it'd be hard to argue with me, and I'll show you why that becomes important later on. But this was a nice example. You can see we're following it down of what ends up being beautifully shown in the coronal view. As you can tell, it's really an adrenal mass. This is an adrenal myelolipoma. There's a little bit of increased density. When you see that haziness, it usually means it's previously bled, and because of this lesion size, it was resected, but there was no doubt as to the diagnosis. Occasionally, when you have large myelolipomas and they're not so sharply marginated, particularly when they're larger, occasionally they can be potentially confused with liposarcomas. That's a potential problem, but not very common. Here's another example, large right adrenal mass. There's multiple areas of high density. To me, that means the patient bled. It doesn't mean it's an acute bleed. If the patient had right flank pain, I would worry about acute bleed. But if you just picked it up routinely, the patient could have bled before. But once you have bleeding within a fatty tumor, particularly when it's so much fat, that higher density area remains. You can see the lesion measured minus 79 Hounsfield units. And this is a classic myelolipoma, but based on its size and the evidence of prior bleed, this patient will get a laparoscopic adrenalectomy. Just a really nice example. And again, the importance, this was a great case because actually initially it was picked up when someone scanned a bit too low doing a calcium score. So you can see often these lesions are incidental pickups, even when they're large, but sometimes when they're larger, of course, patients will have symptoms. And again, just think about that appearance. This is not a liposarcoma. This is not a carcinoma. This is a myelolipoma, just very nicely shown here as well with 3D imaging. Okay, what else? Now, the thing about the last 3 cases, they were basically 99% fat, but myelolipomas can also be lipid poor. Here's an example of a mass, and you could say, well, maybe it's an adenoma, particularly the image on your left. But then when you look closer, there is this macroscopic fat. Remember that adrenal adenoma I showed you before, and there's a little bit of peripheral enhancement. It's kind of interesting. And yes, there's a hemangioma in the liver, but that was a good example, a really good example of a lipid-poor or relatively lipid-poor myelolipoma. Again, because of its size, this was resected. Here's one, again, a very large lesion. The high density was bleeding previously. This is a good example of where I would look at this and say, could this be a liposarcoma? Because the borders are poor. When you look at it quickly, it's really large. You would at least think about liposarcoma in your mind, but then you would look carefully to make sure it's not. Now, another example here of a larger lesion. Based on its size, it's going to be resected, but also the high density means the patient had recent bleeding, which means it's likely to bleed again, which means the best management is going to be resection. Now, in terms of adrenal masses, there are a lot of things that can bleed. The most common adrenal mass that bleeds is pheochromocytoma. Remember, I'm leaving out trauma. Metastases can bleed occasionally. ACCs can occasionally bleed. I mentioned myelolipomas are up there, and the reason we resect myelolipomas is not because of malignant potential, but because possibility of bleeding. And of course, adenomas can bleed, but that is really uncommon. So you can think about the causes for adrenal hemorrhage beyond the masses. It could be bleeding diathesis, it could be anticoagulant therapy, it could be stress. We mentioned things like trauma. Again, there are a number of things that cause bleeding, so not every case of an adrenal hemorrhage is going to be due to an underlying tumor, and at times that's going to be the challenge. When I speak about hemorrhage, and that's what I'm going to do next, is speak about hemorrhage, I'm going to show you some of the challenges in evaluating hemorrhage, why not everything is always clear-cut, and the fact is malignant tumors, be it primary or metastatic, as well as benign lesions from adenomas to myelolipomas, can all possibly bleed. So let's take a little break here. We've kind of used up our time, and let's come back in a few minutes, and we'll talk about hemorrhage. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.